My name is Rafal Wlazel. I work in a laboratory diagnostic department at Medical University of Łódź in Poland, in one of its clinical hospitals. And those co-authors are our cardiologists who helped us to conduct this project. When we are thinking 2 years ago about how to bite the suPAR cake, the temporal prognostic value of suPAR in patients with cardiovascular disease was still not well known. So we decided to assess whether suPAR has any prognostic value in a short time prognosis in patients with their first myocardial infarction treated with primary PCI procedure. What we already believe is true is that suPAR is an independent predictor of adverse outcomes. So we wanted to focus at the short time risk connected with cardiovascular events, as well as to find any correlations with other inflammatory markers, such as CRP, and correlation with left ventricular systolic function. To make this presentation more clear, I decided not to put all the statistical characteristics of the cohort. I must tell you that were 137 among all number of 150 consecutive patients with their first AMI without prior heart failure. Primary PCI procedure was applied as a treatment, and what is very important, those were patients with clinically potentially good prognosis. We measured at the discharge CRP, troponin T level and suPAR level, as well as the CRP on admission to exclude inflammatory process caused by treatment procedures. And we also measured troponin T level each 6-hour period to assess the highest troponin level. As a follow-up endpoints, we defined MACEs, which were as follow: another AMI, revascularization, stroke, and death. What was very spectacular and interesting was that 90% of all cases took places during first 6 months. 90%, that was 42 cases of all 47 cases. The logistic regression analysis showed correlation between suPAR discharge level and probability of developing any kind of MACE with ratio 1.5. When we are talking about ROC analysis and AUC, we can see the curve is not so spectacular for suPAR, with AUC only 0.62, but we need to remember that those were patients with potentially good prognosis. Those cohort of patients, if they did not develop acute myocardial infarction, we believe they would be part of how we call it general healthy population. I didn't tell you about the exclusion criteria, sorry. We exclude patients with diabetes type 1, with kidney diseases, with liver diseases, with cancer, and we also excluded 2 patients who appear to be alcohol abusers. So at the cut of 3.5, we observed sensitivity 90%, and when we switched to the cut of 5.5, we could observe specificity 87%. We believe that somehow reflects the gray area of cutoffs for suPAR between 3.5 and 5.5, but still statistical relevant observations we have for cutoff 3.5. When we are talking about CRP, we did not observe any predictive value, both measured on discharge and on admission and at discharge, sorry. So in conclusions, We thought that suPAR level may be an indicator also for short-term prediction of cardiovascular events after first myocardial infarction, independently of CRP level. The correlation with left ventricular systole infarction, in fact, there was no correlation. So suPAR level did not correlate with ejection fraction, wall motion index, also maximum troponin T level, and myocardial infarction type. And we have all kind of myocardial infarction types, I mean STEMI, non-STEMI, and I think also 2 cases of so-called LBBB. And we believe those results confirm that suPAR level has more prognostic than diagnostic power. We also measured suPAR level at those patients after 1 year follow-up studies, and we observed growth in suPAR level during this 1 year, so that may correspond to intensification of underlying disease processes that causes general health deterioration. To resume the conclusions, which is most important, is that suPAR may be a useful indicator also for short-term risk prediction, also in a cohort with potentially good prediction. We believe those 2 conclusions is something that we already knew, and we are happy that we can confirm it in our studies. Thank you for your attention. Yes, please use simple sentences.
No, actually, I think you're way too modest, because we don't know for this cohort that suPAR might be prognostic also after discharge, because this is something that would really justify like maybe intensive observation afterwards if you have elevated suPAR. So my question is, I was surprised that like the general suPAR level moves up in your good prognosis group of cardiovascular patients. How many did you dissect? How many patients truly had an increase? Like you showed an increase in the mean or median of the population, but was it true for all patients that all modestly increased, or was there a dissection, maybe like some increase with suPAR and half of the population?
I don't remember the actual numbers, but it was the greater majority of those cohorts. That actually we observed increase in suPAR level, yes.
Are you still following them up, the patients, I'm assuming?
Yes, we're still following because, there is one more thing that I forget to tell you about. We observed, we performed also ROC analysis for each particular MACEs, and it appeared that when we are talking about mortality and death, the AUC is 0.85. which we believe also confirms what we already know about suPAR, but the statistics was not statistically relevant, we think, because of small number of those kind of cases. There were only 6 deaths. So this is something what we are looking forward, however it sounds, in the future. I mean, for more deaths, among others, of course. Thank you.